an update on advances in the management of liver cancers and interactive case-based discussion. The speaker tonight is Dr. Tanya Assad. As you know, Tony is a professor of medicine at Mayo Clinic in Scottsdale and the leader of the GI group.
For second line, all studies in second line were done at the heels of sorafenib failure. So that complicates a little bit, matters in terms of interpretation, post-lenvatinib, post-atezolizumab, post-stride. And we can see that, cabozantinib, regorafenib and ramucirumab with alpha fetoprotein more equal than 400, all had survival benefits. When you look at the study with cabozantinib versus placebo Celestial, it did allow essentially patients to fail up to 2 lines of therapy before proceeding to cabozantinib, and indeed about 25%, so a quarter of the patients did have cabozantinib in third line. But if you look at just the patient population in second line, which is the largest group of patients, the survival benefit actually ends up being a little bit better than those including second and third line. And you can see the median PFS there, and then won't expect much response with these agents. So when we look at all these agents in terms of survival, PFS, specifically hazard ratio and response, there's not much to talk about there, and toxicity profile can be a little bit different. And as you recall, I said, the study with pembro placebo post-sorafenib was negative in the US, but was positive in China. And when they combined the data of the two, actually, they ended up with more positive data at a borderline level. But when you look at median overall survival, you can see they all align somewhat similarly on the hazard ratio. When you look at the median PFS, they're actually pretty solid for Rego, for Cabo, even for Ram, but not as solid for pembrolizumab. And that's because pembrolizumab benefits very few patients quite a bit, whereby, the TKIs appear to benefit a lot more patients a little bit. And that's important to keep in mind as you read the data historically. And I'll take this with quite a bit of grain of salt. This is now published in BMC Cancer, and this is looking at that incredibly small subgroup of patients who had third-line cabozantinib and were exposed to prior PD-1, PD-L1. If you look at the data, all what it suggests is that cabozantinib appears to do fairly similarly, whether pre-exposed to PD-1 inhibitors or not. That's the best conclusion you can come out with for the small number of patients. And that's good. We don't have much data there, but that certainly helps understanding, whether these are safe and reasonable to use post-IO. Now, when we think about, our first line for most patients shifting primarily to atezolizumab, and then for some durva-tremi, the thought is, how do we pick options now post-atezolizumab or durva-tremi? So when we look at least atezolizumab, which is the majority of our patients, it doesn't make as much sense to think about, more VEGF target therapies, and mostly ramucirumab and lenvatinib, which primarily target VEGF, make a little bit less sense post-atezolizumab. So sorafenib doesn't have much data in the second line, and is relatively tough drug, and for most of us probably happy not to have to use it again. So really, regorafenib, cabozantinib end up being preferred, and I would say, there's probably an edge for cabozantinib, theoretical edge, that is, because they've never been compared head-to-head. And that's based on the renal cell literature, which does suggest that, for those, and these were in mice model, resistant to sunitinib, essentially upregulation of MET and AXL, and so blocking MET and AXL through cabozantinib, which it targets, did reverse the resistance to VEGF inhibition. And so cabozantinib, which is a multikinase inhibitor, also seems to have those targets, would make quite a bit of sense post-atezolizumab. Rego would be also acceptable. For durva-tremi, which is probably, I would assume, less used, it's a it's a bit more difficult to say. I still would stick with Rego Cabo, but I would say that lenvatinib or even ramucirumab are not unreasonable options in this subgroup of patients. Of course, for RAM, it's more equal than 400 for AFP. We published this in 2020. Our group did that, and essentially, what we've shown essentially is atezolizumab certainly, appears to be superior as expected, but I think what comes out of this paper is that cabozantinib and regorafenib, are preferred over others in second line. So overall, I think atezolizumab remained the primary current standard for most patients, although, durva-tremi seems to be a reasonable, or STRIDE seems to be a reasonable alternative. And then sorafenib, lenvatinib for those, say, that have solid tumor transplants or what have you. Second line options really depend on first line options. I do personally favor cabozantinib or regorafenib, but others are also acceptable, although in need of more data in refractory settings. Still, find Charles PB to be quite a challenge. These patients do worse. There's not much data there. I mean, those are the patients I may consider, if they're fantastic performance status, to dual therapy with atezolizumab. If borderline, single agent durva may be an acceptable regimen. So we're trying to move a lot of these now to earlier lines. You've heard about the Genentech study 050 in the adjuvant setting, post-resection or ablation, and that was positive. And so as we're moving some of these systemic therapies now into earlier stages, we continue to see some positive signals, unlike the prior negative signals. That was IMbrave 050. Thank you, and let's go through the cases.
So this is a patient who's 68 years old who had HCV, alcoholic cirrhosis, and HCC in the right hepatic lobe. When I saw him was Child-Pugh B7. He had been through multiple local regional therapy treatments with TACE and Y90-TARE 4 times over the past 4 years. Was fairly healthy otherwise, other than CAD, and actually was referred to discuss systemic therapy because just because of his social situation, he wasn't a candidate for transplant. His disease was mostly had spread to the right hemidiaphragm, and staging was T4 and 0 and 0. But talking about systemic therapy for him, because he really had no other local regional options and wasn't a transplant candidate. So I was wondering, with some of the new data, like we talked about with him being B7, do you think he'd be a candidate for atezo-bev, or would you do dual immune checkpoint inhibitor or single immune checkpoint inhibitor?
So he's Charles-Pugh B7, good performance status?
Yes.
Good performance status, and quite cirrhotic. I mean, this is a patient, and I'm assuming, risk of bleeding assessed and reasonable. So I would go with atezolizumab for this patient. It actually is interesting. There's some, when was his last Y90?
Just under a year ago.
Okay. I mean, there's some data that suggests that essentially TACE, and more so Y90 actually, more than TACE, because of the radiation component, that may actually enhance the capacity for two things, for PD-1, PD-L1 inhibitors to actually have a benefit, but also VEGF inhibitors may help with, reorganizing parts of the tumor and make, again, PD-1 inhibitors more likely to be successful. So, but this, the time frame is further out. I think STRIDE is reasonable. I'm sorry, single agent durva is reasonable. I don't see an advantage for STRIDE for a patient with Child-Pugh B7. If you want to go with single agent, IO, I'd do either durva or nivo, but durva at least has this positive, well, non-inferiority, but it's positive. But for this patient, I I would consider atezo-bev cautiously, but I would get a better response, and you're likely, going to see. You won't see the responses we see with Child-Pugh, but there is a possibility to see a good response. And he wants to be aggressive, I'm assuming.
Yes. Yeah.
Yeah,
Thank
that
you.
would make sense. And his disease seems to be less aggressive, so biologically may end up actually responding. This whole Child-Pugh score can be relatively artificial, right? I mean, it's an old scoring system. There are two elements that are very important, for assessing actually prognostically true function. It's albumin and bilirubin, more important than everything else. So those can be even more prognostic for this patient. So atezo-bev.
Tony, before you do the second case, there's a question just came in asking if there's any data on the potential role of immunotherapy as neoadjuvant prior to local regional therapy.
Yeah. So there is, it's not large on a large scale, but there's a study with ipilimumab and nivolumab that ran out of MD Anderson that showed some, I think about 40+% of the patient having pathologic complete responses prior to surgical resection. I can tell you that in I'm sure a lot of you who may be attached to a transplant center, that we've been seeing a lot of these solid responses translating with atezo-bev and others, translating into patients who were not eligible for transplant, becoming eligible for transplant, with caveats, of course, that you have to stop that IO agent for quite a while, establish stability, and then placing them on the transplant list. And there are studies that are looking at this actually with durva-tremi, with atezo-bev. So yes, there's quite a bit going on. We don't have phase 3 data. We have a lot of good phase 2 data. The only phase 3 data that's positive in the adjuvant setting is this IMbrave 050 with atezo-bev. We haven't seen the full results yet, which we're waiting on, but it looks like these regimens, as they move to earlier stages, are probably going to produce similar benefit than what we've seen with the more advanced setting. Okay, let's move to the second case, Dr. Decker.
Yes, so it's a little bit different case. It's a little bit different scenario. Again, for whatever reason, my patient is also 68 years old. But in this case, actually, he had hypertension, obesity, diabetes, and NASH was really his only risk factor for HCC. He had elevated alpha-fetoprotein since 2016. He had imaging done by his primary. At that time, he had MRI, did not show anything. It was checked once a year and was bouncing 12, 16, 18, 15. But in May 2022, it came back 140. He had liver MRI. I decided to copy the full report. To me, he appeared to be transplant candidate, but he had transplant evaluation at a local academic institution. It was determined not to be a transplant candidate. As you see here, they do comment that he has mild cirrhosis. He actually had almost perfect performance status. He actually quit working when he was diagnosed. He was an electrician, basically putting wires up on the poles. So In my particular case, I skipped liver-directed therapy at that time and decided to go with Avastin anticentric. Alpha fetoprotein briefly improved, started to go up. He had one round of Y90 and didn't appear to touch it. Evidence radiologic disease progression, most recent alpha fetoprotein 264.
Well, so what are you thinking right now?
So basically, we have not hepatitis disease. It's clearly second line, really no good response to VEGF, no good response to Y90. I was thinking about something like Cabo in this setting as the second line. It appears to be as efficacious as anything else, maybe a bit more efficacious, at the same time, probably more predictable toxicity and tolerability.
I agree. I think, you know, for this one particular patient, I definitely would favor cabozantinib. I totally agree. And again, because, you know, you have a patient who's failed, you know, a PD-L1 inhibitor, so I wouldn't certainly consider IO again for this patient. And it was a brief response at best, so, you know, it's a heavy lift to even think about it. And a VEGF inhibitor, which makes lenvatinib, for example, you know, less attractive. RAM. So cabozantinib and regorafenib would be the options that go with as I discussed, you know, probably favoring a little bit more cabozantinib for the reasons.
I do have a question. Let's
Yeah.
say I go with Cabo.
Mm-hmm.
Let's say he had a response for X number of months. Then disease will again progress.
Mm-hmm.
Is there, in your opinion, any point again to give CTL4 PD-1 combo?
The only time I would consider it is if there was a good response in the first line. You know, that's the only, and that's, you know, across other malignancies, there are signals that if you have a solid response for single agent in the first line, then, you know, adding CTLA4 may benefit a small percent of patients if, you know, there was a decent response in the first line, which hasn't happened here. So I wouldn't, you know, probably go down that path with that patient.
Okay, thank you.
All right, thank you. Great case, thank you. All right, June, how are you, man? Next one is yours.
Hey, Tony, Happy New Year.
Happy New Year to you too.
Yeah, this is a 71-year-old woman, chronic hep C cirrhosis. Earlier this year, found to have a small mass in segment 4B. However, there was already initial comments, may not be typical of HCC based on radiographic criteria. However, AFP was elevated. Was referred to our hepatobiliary team and underwent kind of a concurrent diagnostic biopsy and microwave ablation of this lesion. The biopsy showed poorly differentiated carcinoma, favoring HCC on morphologic stains. As you can see down there, glypican strongly positive, HepAR weak to negative, but immunostains showed strong CK19, which the pathologist was kind of indifferent and said could be cholangiocarcinoma as well. We did send NGS and noted that there was TP53, TSE2, and a TERT promoter mutation as part of the pathogenic mutations found. Imaging after ablation showed no viable tumor. However, within about 5 months or so, interval development of an expansive viable tumor in segment 4-8, invasion in the right portal vein, complete occlusion, Again, radiology was a little bit mixed, HCC versus cholangio with portal vein. And then enlarged portocable lymph nodes favoring metastatic disease. So Tony, this is kind of I guess a common scenario on tumor boards
Yeah.
sometimes.
Yeah.
Was wondering what your thought on based on this presentation. Should we treat as HCC, cholangio, or kind of a mixed biphenotypic type?
Yeah, I mean, that's interesting, right? As you said, we're seeing more and more of these mixed histologies, especially, with chronic liver disease. Anthony Laqueri, presented that data with IMRAVE 151, which may have shown just a tidbit of a signal, right, in cholangiocarcinoma, but at least I'd say, showed that GemCis atezobev is safe, relatively safe to use. So I'd be tempted in this patient to do a GemCis atezobev. You'll hit both. I probably would limit GemCis to 4 to 6 months, or go with every other week, and continue with the atezobev. I mean, there was a little signal for cholangio. It wasn't meaningful enough. Although, you never know where that goes beyond. It was an underpowered study, but at least you have, now a safety data with GemCis atezobev, which would cover both bases for you.
Gotcha.
Now, is that what you were thinking, Kana?
Yeah, and I was thinking, even your data as you reviewed with Durva, it's kind of nice how the Topaz one cisgem has Durva in it now, which kind of helps us a little bit with this mixed.
Yeah. Yeah.
I was just thinking about that.
Yeah, you're right. I mean, GemCis Durva would also be acceptable. Durva single agent, does have enough activity to be interesting, but I still would favor GemCis if you can get away with it.
Yeah.
GemCis atezobev, you'll get a little bit more oomph, and not much more toxicities, frankly.
Yeah. So Tony, are you guys kind of standardly biopsying all your liver masses, even though if there's kind of radiographic diagnoses of HCC?
Yes.
Okay.
One because of this, because you're going to see more of those, and two, because it's for clinical trials, you're almost obligated to, unless you think the patient is going to go for transplant. Transplanters get quite finicky about biopsying those lesions. Other than that, patients are getting biopsied standard.
Right. Thank you, sir.
All right, thank you, my friend. Okay, Charles, anything else?
No, I think that's the cases for tonight, unless anybody has a question they would like to ask.
All
If
right.
not, we'll go ahead and close up shop and thank everybody for taking some time out of their evening for tonight's discussions. And with that, have a pleasant night.
Thank you.
Thank you.
Thanks all. Take care. Bye-bye. Thank you.
Thank you.
Good night.
Bye.